Welcome everybody to this 21st Uveitis web seminar, and the topic today is going to be about syphilis, a disease which is a scourge throughout the world and in many parts is increasing in frequency. So I think it's a very good topic to have and to discuss with a fantastic panel of individuals. And I would particularly like to welcome Rina and John, because they're part of our education committee, and in some ways they're going to be very important in the coming months to try and give a new focus with these ongoing webinars in terms of the content and how we will be doing it. And as I was discussing with Vishali earlier and also with John and Rima, if you can provide us comments with particularly new topics or areas that you would like us to stress, or maybe even the formula that is being used, please let us know. We're certainly open to suggestions with regards to how we should do this so we make it as interactive and interesting possible to our worldwide audience. And without further ado, I'd like to welcome, of course, Vishali also, and all of you here. And I'd like to thank our sponsors, that is Allergan AbbVie, that has made this possible, as well as the support from the Uveitis Society of India and the Asian Pacific Intraocular Inflammation Study Group. So I'd like now to welcome Carlos Pavesio, very well known. I don't think I need really to introduce him, and he's going to give us an introduction, historical perspective of syphilis. Carlos?
Thank you, Mark, for the introduction, and it's a real pleasure to be with all of you here. Let me just make sure I can put this in a presentation format. You can see my slides now?
Yes.
Yes, wonderful. Okay, let's get started here. It's nice to be part of this group and to be sharing with you a few interesting, sometimes amusing aspects of all syphilis as well. As Mark said, is a condition that is around, it's on the increase and never left us, so it's important to think of it. And I'll just go over a few historical facts and a little bit of interesting facts to share with you. So if you look at the theory behind where syphilis comes from, and this is just like the context of who is responsible for this dreadful disease, and you can see here that the theory is that it actually came from the New World and then it was spread, and the other one is that actually was already present in Europe before there were Europeans in America, and then it was brought back. So you can see reports of syphilis in writings from Hippocrates in classical Greece. So it's certainly more likely that it was already here, and of course could have happened in other parts as well, but I think it's more in favor of already being present. The first outbreak that was recognized in Europe was in Naples and during the French invasion, and then it was kind of known as the French disease for that reason. The first time the term syphilis was used was a poet, an Italian physician and poet, Girolamo Fracastoro, and writing in Latin, he said, Syphilis sive morbus gallicus, which means syphilis or the French disease. The organism was identified in 1905 as Treponema pallidum, and was identified by Fritz Schoden and Erich Hoffmann. So what's in a name? So that's the interesting thing, so interesting if you look at this, because the disease was so dreadful and had a stigma around it, everyone was blaming the next one for it. So the neighbors or someone they didn't like. So if you look at what the Italians and many others felt was the French disease, but then you look in France, it was the Italian disease. The Netherlands felt it was the Spanish disease. In Russia, the Polish disease. The Turks felt was the Christian disease. The Hindu blamed the Muslims. But in the end, everybody blamed the Europeans. So effectively, it was something that, as we discussed before, most likely was already present here. And because of all the issues we know about, it spread throughout Europe and other parts of the world during the invasions and conquests. As I mentioned before, a disease which is around, you see the CDC report 2020 indicated the number of cases of infectious sexually transmitted diseases, including syphilis, it was quite high. But if you look at the figure, actually, in terms of global figure, it's about 12 million new cases of syphilis per year. So most of them occurring in developing countries. So it is a condition that is definitely to be kept in mind. Don't forget that when you have syphilis, there are clinical manifestations of the disease, which are systemic manifestations that we all have to be familiar with, because they will give you good clues about the potential problem that you can see when you're examining your patient with an eye problem. So the understanding of the primary forms, and it is a bit of history here as well. If you look at Peter Watson's Scleral and Systemic Diseases book, there is one mention that I think in Russia there was an epidemic of scleral primary lesions. So you can imagine how it is possible to have scleral primary lesions. So it was in a factory, and it seems that one of the guys had a job of removing foreign body from the eyes of his colleagues using his tongue. And then you can see how that happened. So he had a primary lesion and spread it to his colleagues, causing this epidemic of scleral manifestations. So secondary disease, classic palms of the hands, and of course tertiary syphilis with neurosyphilis and gumma manifestations. So it is a great pretender. It can certainly, it has to be kept in mind for a lot of things you see. So in the eye, you can see here all the different possible manifestations, from the conjunctiva to neurologic problems, all the things related to syphilis, which means you have to keep it in mind for whatever ocular manifestation that is in front of you. So essentially, anyone presenting with a simple red eye, you have to consider it. And then you have the other manifestations, which are part of our differential diagnosis of patients with granulomatous uveitis, corneal interstitial disease, fibrinous anterior uveitis, a picture more of a scleritis, and of course, this more famous kind of placoid presentation that been recognized by all of us. The diagnosis, in terms of laboratory diagnosis, evolved from when it was discovered. The Treponema pallidum was discovered in 1905. It was interesting that it could be only seen in one technique, which was developed the following year. And it was exactly dark field microscopy. So we can see the treponema, but it's only if you take samples from the eye, from primary lesions, not the eye, from primary lesions. So it's difficult to identify in other sites. And even from the mouth is a problem, because in the mouth we may have some treponemas that are not Treponema pallidum, and it's impossible to distinguish them. We have the first test, which was devised to serologically identify, and this is the non-treponemal test. The first one was the Wassermann test, which was also, you can see curiosity here, Albert Neisser was exactly the person behind Neisseria gonorrhea. So this is this guys together they developed this first test as a complement fixation test. In 1949, they found that when you were able to, using the serum of patients with syphilis, inhibit the movement of Treponema pallidum, that led to another test, which was the immobilization test. Which was introduced by Manfred Meyer and Robert Nelson. So this was the first non-treponemal test. Sorry, not the Wassermann test. So the direct identification, microscopic identification, the dark field I mentioned to you before. It is the problems with the having the necessary equipment, the necessary training to be able to identify, and the limitations of where you take your sample from. Then you have immunohistochemistry, which will allow you to identify in samples, in specimens, the presence of the treponema using special staining and antibodies. So the tests that we are more familiar with are the serological tests. And there are two types of tests, the non-treponemal, and I mentioned one to you before, and they are the ones that are very useful in detecting activity of the disease and able also to detect if there is a response to therapy. These tests, they don't appear very early on. And they are measuring not the treponemas, they're not specific. They are measuring antibodies to cardiolipin, cholesterol, and lecithin. The treponema-specific tests, so these are the detection of specific antibodies, are measuring IgM and IgG. So they respond very early on. Especially IgM is the first one that will appear, and it will become negative in about a couple of years. But the IgG will remain positive forever. So this is going to be a serological scar. And the tests that are most frequently used here, the TPPA and TPHA. These are the tests that were more frequently used. So we're showing here very briefly to you the sensitivity and the use of these tests. And you can see, as I mentioned before, the IgM treponemal test, they react very quickly. it will fade and disappear after less than 2 years, and then you have the IgG, which will remain positive for the life of the person. So that test will always be positive. The non-treponema will give an indication of response to treatment, and especially if you can see it is reducing, and clearly if you're not responding very well, might be incomplete or failed treatment, or eventually a reinfection. The treatment history is really interesting because you can see that initially plants were used, plants brought from the New World, and they were treated as leading to what we call blood cleansers. They'll try to get rid of the bug in your system by creating all these unpleasant reactions in your body that would then get rid of the agent. Mercury was also created as a potent diuretic, excessive salivation. So again, sweat, salivation is only trying to see if the organism would leave the body via this very particular forms of unpleasant sensations. The bismuth salts became the most important heavy metal in treating syphilis. It was less toxic than mercury, and it still had a bactericidal effect better than what you can get with mercury. Paul Ehrlich got the Nobel Prize because of the discovery of sulfur sand. So arsphenamine was called compound 606. The reason for that is all the previous experiments had failed. So 606 is the one that worked. So it was labeled as compound 606. New sulfur sand, also an arsenic compound, less toxic and more water soluble. In 1928, that's when the breakthrough came with Alexander Fleming discovering penicillin. And essentially it became the drug of choice for the treatment of syphilis from 1943. So just to mention to you that if you look historically, there are many famous faces that have been associated with syphilis or possibly associated with syphilis. So William Shakespeare, you have Beethoven, Schubert, Abraham Lincoln. These are people who are considered to be very clever, genius in their lives. Lenin, and then of course there's some bad people too got it. Lenin, I would say, I wouldn't classify him like that, but yes, Al Capone, I would say, is a nice guy, and the ultimate bad guy was Hitler. He also apparently had syphilis. So when do you consider syphilis? I would say always keep syphilis in your differential diagnosis. Is a condition that can be treated, can be eradicated, so you can handle the problem very well, and if you ignore it, it will go on and cause more damage. And always remember an important fact: reinfections may occur. A lot of the patients that are infected have habits that are associated with high risk. And always remember also that HIV and syphilis do walk hand in hand in many of these patients. So if you see someone coming back, even if they totally been treated before, you have to retest. You have to consider that they are at risk of re-exposure, reinfection, and don't forget also to test for HIV, because these are individuals who belong to a high-risk group. So I hope this covers very briefly a bit of the history of syphilis in general terms, and I'm sure there'll be a lot more for you to see more specifically in our field of ophthalmology. So thank you for that.
Well, thank you very much, Carlos. I think this was a very, very complete introduction, and it now will be looked into more details by our next speakers. And the next one is Ahmed Salman, and he'll be talking to us more about the epidemiology and the mode of transmission, and give us a little bit more detail about HIV and non-HIV cases. Ahmed?
Thank you so much. Thank you, Mark, and a great presentation, Carlos. Let me share my presentation here. So yeah, I practice in Arkansas, and we have a very big population of syphilis in Arkansas currently, really. So I'm not going to spend on the history, but as Carlos said, the thought is that it came really with the Colombian voyage, and that's really how it came, and more likely than it was there before the pre-Columbian history. I just want to touch on important dates here. Mainly the 1980s were the AIDS crisis and the rise in the rates of syphilis, and then after that, with managing of the AIDS and more attention to infection rate, the rates got to plummet down. Then in the 2000 and currently rates are going, for 2000 we had like lowest rate because again of the awareness of the syphilis and the treatment of syphilis. But from 2010, things are going up, particularly in Europe, maybe because of more men having sex, social networking, also more of the change in behavior and acceptance for the presence of HIV and treatment of HIV. So the rate seems to be going up, and that's as a concern really currently, and we see that as well in Europe and America. Now, regarding transmission of syphilis, we know it's a sexually transmitted diseases, and that's the main methods of transmission. It also happens to vertically or transplacental transmission, and particularly if the mother is at the second stage of syphilis, that's where the infection rate can be the highest to the baby. Risk factors, the most important risk factors to consider is unprotected sex, men having sex with men, and multiple sexual partners. HIV is a very important co-infection, and the rate can be up to 10% in some series. So what about the pathology? So we know that Trichinella pallidum is a spirochete, is a microaerophilic, very fast-growing organism, and human is the only host for the organism. The infection happens, as we all know, it penetrates the skin and mucous membrane at the site of inoculation, and it happens more if there are breaches in the mucous membrane and the skin, and that may explain the higher risk in case of men having sex with men. Then after that comes the next stage of tissue dissemination, and the organism can traverse the blood-brain barrier, the blood-ocular barrier, and the maternal-fetal barrier, as we discussed. It's an extracellular pathogen, and one of the interesting things is that why it escapes immunity is that the surface-exposed pathogen-associated molecular patterns are very little on this spirochete. So it actually may explain why it escapes the innate immunity, and also may why the systemic inflammatory symptoms are not so marked with syphilis, and that can lead to an asymptomatic infection. It's unculturable, and there are lots of theories why we cannot really get like culture of syphilis as easy as it should be for other organisms, but the main reason is still unknown. But so far we cannot depend on culture to isolate the organism. It has been studied in some lab animals of inoculation into animals, but the main method to prove or disprove syphilis is mainly, as explained by Carlos, is depending on serology. What about the immunity? How does the immunity work against syphilis? Opsonic antibodies is a very important mechanism against the spirochete. So these antibodies attach to them, they make them more easy to phagocytose and to deal with by the macrophages and the T cells. And you get a complex inflammatory reaction of macrophage, CD4 and CD8. Interferons is produced at a high level. This is very important to recruit macrophages, but also it results in inflammatory reaction, and that's the problem. That inflammation itself can cause damage. And that may also explain why steroids are used not routinely, but are used during the treatment of syphilis alongside the penicillin treatment. Okay, we all know about the stages of syphilis. We have an incubation period of 9 to 90 days. At that time, the spirochete is in the blood, but the rate of spirochetemia is not very high. Then we have a primary stage, which usually at the site of inoculation, an ulcerative lesion, which is one of the hallmarks of the disease, and it's in the form of chancre. Then you go into the secondary stage, and that stage where spirochetes is the highest in the blood, the serology titers are highest, and the immunity as well, immunity interaction is really high with the organism. It's interesting that although the antibodies rates are very high, still the spirochetes survive at that stage untreated. And that's where you can have rash and alopecia and interstitial keratitis. And uveitis happens at any stage, but most commonly at the secondary stage. After that, we go into a latent period, which can be divided into early and latent, where there are no symptoms, but still there's infection going on. And the levels and the antibodies level at that stage can be reduced compared to the secondary stage. Then about 30% of untreated cases will go into the tertiary cases where you get neurosyphilis or cardiovascular involvement, for example, aortic arthritis. In the one important thing to know that in the latent period, especially the early part of the latent period, you can get like a secondary stage like of syphilis. You can get a sort of like an appearance like a reactivation, or the patient can get symptoms like the secondary stage in the early, about 25% of patients in the early latent period of the infection. I think this one, I'm sure this is going to be discussed more in the serology lecture. But you can see here what happens with the primary stage and the secondary stage with the antibodies, the IgM, and then the IgG coming up, and the levels really being very high in the, especially the IgM in the secondary stage, and then levels going down, particularly of the IgM into the latent stage, as we discussed. And this is important to understand for what test to order and also how to interpret the test. Very important question. So we treat with penicillin. This is very well known. Is there any resistance to penicillin? Not to penicillin. There is no clinical resistance to penicillin that we're aware of, but there is clinical resistance and genetic resistance that was proved to macrolides. So as a secondary line agent, we have to be as a second line agent, we have to be careful that actually there are cases where the syphilis is resistant to macrolide treatment, including azithromycin. What about reinfection? Reinfection can be an issue, and mainly it's related to the lifestyle of patients who are at risk. So multiple sexual partners and men having sex with men increases the risk of reinfection. In one series, the risk was up to 50%. Interestingly, a study from Belgium showed that the reinfection, the immunological and the clinical responses can be attenuated. So patients tend to be more asymptomatic, and that really can make the diagnosis difficult. So something to be aware of, that reinfection rates are high, particularly in patients at risk. Coming to syphilitic uveitis, the reported incidence of syphilitic uveitis varies between centers, between maybe from 0.5% to 10%. In centers, as we've seen in Arkansas, it's in the range of 10%. It happens at any stage, but mainly in the secondary stage. I just want to share with you here some data from a study we did from Arkansas. We looked at the patients of syphilis in HIV positive patient and HIV negative patient, and that was a retrospective short review. And most of these patients, all of these patients actually were diagnosed based on reverse sequence syphilis screening, or patients who came to us already with systemic syphilis. So we had 68 patients, 68 eyes of 41 patients. The male to female ratio was about 2:1, and the mean age was not different between the two groups, and it was in the range of about 45 years old patients. We had more Caucasian patients than Black patients, and we had bilateral disease in about 65% of patients. Obvious risk factors was present in 53% of patients, and that was in the men having sex with men and drug users, and 3 patients had incarcerated, whether that can be itself counted as a risk factor. What about patients who What about patients' presentation? Uveitis was the most common form of ocular syphilis, as we would expect, and posterior uveitis was the most common form of uveitis. Posterior uveitis included the patterns that we know about: retinochoroiditis, peripheral necrotizing retinitis, similar to ARN, retinal vasculitis, and posterior placoid chorioretinitis. Posterior uveitis was more common in HIV-positive patients, while anterior uveitis was more common as a presentation in HIV-negative patients. We had 3 cases of reinfection or documented reinfection, and that was based on recurrence of ocular disease as well as blood serology going with this. In this study comparing HIV patients and positive patient and HIV-negative patients, we really did not find any difference other than the pattern of uveitis, which was the posterior uveitis, more common in HIV-positive patients, and anterior uveitis being more common in HIV-negative patients. So I think to summarize, as Carlos have alluded, syphilis is a great masquerade. We have to be aware of it. It's on the rise, and especially when there is a risk factor, it has to be considered very seriously, and serology is the main method of diagnosis, and penicillin so far remains a very effective treatment, but reinfection rate can happen particularly in patients with HIV and patients with risk factors. Thank you so much.
Thank you very much, Ahmed. This was a very comprehensive and overview, and at the same time, I think very clear messages with regards to how to treat and the care you need to take with regards to reinfections. And we need to re-emphasize all of these things, in particular the fact that having a positive, HTABS doesn't mean necessarily that a person can be reinfected. The next talk is going to be by Jolanda de Groot, a former colleague from the Netherlands, from Utrecht, and she's going to talk about the microbiology and the pathogenesis. This is a recorded talk. She wasn't able to be present with us. So if the people from Global Conference can put her talk onto the screen, let's listen to what she has to say.
Good afternoon. I would like to thank Dr. Gupta and Dr. Desmet for inviting me to speak here about the microbiology and pathogenesis of syphilis. Unfortunately, I cannot be present, so I hope you will enjoy my recorded presentation. I would also like to thank my colleague Dr. Ninette ten Dam for sharing ocular photographs. In addition, the literature used is shown here. Syphilis is a disease caused by the bacterium Treponema pallidum, subspecies pallidum. It is a gram-negative spirochete and has a genome of just over 1 million base pairs, which makes this one of the smaller bacteria. For comparison, E. coli, also a gram-negative bacterium, has a genome of 4.5 million base pairs. Together with bacteria from the genus Borrelia, which contains the causative agent for Lyme disease, Treponema species belong to the family of spirochetes. These are bacteria which are characterized by a typical twisted structure shown here, and have a corkscrew motility which is demonstrated in the next slide. Responsible for the twisted appearance and corkscrew motility are endoflagella, these blue strings and these blue dots. They are situated between the bacterial cell wall and the outer membrane. They are twisted around the cell and are attached to motor protein complexes, shown in this slide. These motors cause the flagella to move perpendicular to the cell axis, which results in a typical corkscrew movement. Treponema species can cause several diseases in humans, of which syphilis is the most widespread. Other presentations are Yaws, Begel, and Pinta. It was previously thought that each disease was caused by a different species of Treponema. However, genotypic analysis demonstrated that only Pinta is caused by a different species, Treponema cariateum. The other three are caused by subspecies of Treponema pallidum, Syphilis by subspecies pallidum, Yaws by subspecies pertenue, and Bejel by subspecies endemicum. It was long thought that Treponema pallidum was the only Treponema causing venereal disease. However, recent reports suggest that Bejel can also present venereally, particularly among men having sex with men. Still, syphilis is the most important venereal disease among the Treponems. Morphologically and serologically, these species and subspecies are indistinguishable, and the diagnosis is usually made based on geographic location and clinical presentation. Syphilis pathogenesis is poorly understood. However, several phases can be discerned, which are reflected in the different stages of the disease. First, the bacteria enter through the mucosa and small skin abrasions. There they can attach to underlying cells where they start replicating. After a median incubation time of 21 days, primary syphilis develops. It involves mainly adaptive immune responses, including infiltration of macrophages, CD4 positive T cells and plasma cells, and increased expression of IL-2 and interferon gamma. This gives rise to the classical chancres at the site of entry, shown here. Generally, the lesions heal spontaneously within 3 to 6 weeks. Following multiplication near the site of entry, the bacteria pass the endothelial monolayers to gain access to the blood and lymphatics, resulting in widespread dissemination. The bacteria are highly capable of attaching to the endothelium, for instance, through the interaction of the Treponema adhesin TP0751 with the laminin receptor LAM-R. This strong attachment allows the bacteria to reside and multiply in a nutrient-rich environment without being flushed away. Within weeks to months after initial infection, secondary syphilis develops, which results in systemic illness in 25% of patients if left untreated. Disease manifestations include rash, shown here, condyloma lata, which is highly infectious, and a multitude of other systemic inflammations, including uveitis. Immunologically, cell-mediated immune responses dominate with a majority of CD8 positive T cells. Throughout primary and secondary syphilis, high levels of anti-treponemal antibodies are detected. These are in some part able to immobilize treponemas in the presence of complement and prevent attachment. Increased apoptosis of peripheral blood leukocytes and CD4 positive T cells is thought to result in incomplete clearance of the bacteria, leading to chronic infection. Following secondary syphilis, the infection can become latent, which is a stage by definition asymptomatic. Apparently, in this stage, the mounted immune responses are sufficient to control the infection. 2 to 30 years after initial infection, in approximately 30% of cases, tertiary syphilis may develop as the disease becomes active again. Typical for early tertiary syphilis are chronic proliferative inflammatory processes in skin and various internal organs. These granuloma-like lesions are called gomata, as shown here for the skin. Manifestations of late tertiary disease are cardiovascular syphilis, neurosyphilis, and ocular syphilis. Perhaps the key feature of syphilis to cause neurological, ocular, and congenital disease is the treponema's high capability of passing through the respective specialized barriers, giving rise to neuro, ocular, and congenital syphilis. Attachment of treponemal adhesin TP0751 to LAM-R plays an important role in this process. These data demonstrate that antibodies against TP0751 can greatly inhibit their adherence to cells. Recent in vitro studies also showed that T. pallidum, here in red, co-localizes with tight junctions as visualized by V.E. cadherin in green. Previous and this study showed that attachment of TP0751 disrupts the tight junctions as shown in panel 4, suggesting that this may be a way to cross the endothelium. Further investigations by transwell experiments demonstrated that the bacteria can transverse the monolayer of cells without disrupting its barrier function. In these experiments, Treponema was added to a well with a monolayer of cells in the transwell system. The bacteria was subsequently detected in the bottom part, but the barrier was maintained as observed by the difference in fluid level. This led the authors to propose that Treponema pallidum can transverse the endothelial barriers by two routes, similar to those previously described for leukocytes. On the right, the paracellular transversal, where the bacteria disrupt the tight junctions. After the bacteria have passed, the tight junctions are restored and thus also the barrier function. On the left, the transcellular traversal, where bacteria gain access to the cell and transfer the cell by means of transcytosis without disrupting the barrier function. Syphilis is often called the great imitator, as it is capable of spreading throughout the body and cause disease at a multitude of sites, including the immune-privileged ones. This success can be attributed to stealth and various virulence factors. For one, the treponemal outer membrane. Unlike other gram-negative bacteria, it lacks LPS, an important activator of the innate immune response. The outer membrane does contain ample lipoproteins which may function as pathogen-associated molecular patterns, but these do not seem to activate the innate immune responses to a great extent. The outer membrane also contains various protein complexes functioning as porins for nutrient intake and attachment proteins. These can be expressed differentially depending on the environmental requirements, resulting in antigenic variation, which is important for immune escape. During primary and secondary syphilis, viable bacteria are present in circulation despite high titers of anti-treponemal antibodies. These antibodies are mostly non-opsonizing and thus do not help macrophages and other phagocytic cells in clearing the bacteria. Of note, a previous treponema infection does not necessarily protect against reinfection. Other factors contributing to the virulence are attachment to endothelial cells, allowing the bacterium to reside in the nutrient-rich blood without being flushed away. In addition, in the blood, the bacteria coat themselves with fibronectin, shielding them from the immune system. And finally, the motility apparatus. The corkscrew motility allows the bacterium to travel through mucosa, endothelium, bodily fluids, and by embedding the flagella within the perimeter of the outer membrane, these highly antigenic structures are shielded from the immune system. So syphilis and its causative agent are truly the great imitator and master of stealth. The sharp increase in syphilitic disease over the past 2 years has sparked renewed interest in its pathogenesis, and I expect many new and exciting insights in this fascinating disease over the coming years. Thank you for your attention.
This was a very nice talk. I think it was very instructive. Unfortunately, we won't be able to ask questions of Yolanda. Our next speaker is Cristina Muccioli from Brazil, and she will go over more of the clinical presentations of syphilis. So, Cristina, we're looking forward to what you can tell us.
Thanks, Mark. Thanks for inviting me and to give me the opportunity to share some challenging cases with you. Okay, so here we go. Let's put some fun on the course. So this is the first case on a 40-year-old male complaining about decreased visual acuity in both eyes. This patient was treated previously with Bactrin in another clinic, then because of the worsening of the VA, was referred to our clinic. So here is the patient. VA of count fingers and 20/60, and anterior chamber reaction. You can see this posterior synechia. And I want to ask for your attention to this presentation. This is a very intensive vitreous involvement, and with this vitreous infiltrates, like it's a very, very, very suggestive of syphilis. So when this is the other eye where we can find some retinitis. So this, and here is the obvious, a positive syphilis exam. This patient was treated with IV penicillin for 14 days, and here's what happens, like huge improvement. And we can say for syphilis that when we make the correct diagnosis and treatment, we cure patients. So it's very, very important to keep this in mind. And just to ask for your attention on this superficial retinal precipitates, it's not specific for syphilitic retinitis, but it's very, very suggestive. So if you see this in a patient, you can start right away to give penicillin for the patient. This second case is for a 40-year-old female patient complaining about decreasing VA for 6 months, and the patient told us that she presented with oral and genital ulcers, as well as joint pain, hypoacusis, and behavioral changes. And at that time, she was started treatment for neurobichette with prednisone, mycophenolate, infliximab, and eye drops. So she presented with worsening of VA and then referred to us for second opinion. Here's the patient in the beginning. The vision was 2400 and 2800. And here's what the eye looked like. So anterior chamber reaction with this KPs, brown KPs. And here is the vitreal involvement in right and left eye, very similar, both eyes, as you can see here. And this is very important. The rash, cutaneous rash, that was taking consideration that it is like some other disease. And then you can see hand and foot, and this is what happens. Positive serology for syphilis. She was HIV negative and was treated for 14 days with IV penicillin. And here's what happened. We cured the patient, no more anterior chamber reaction, no more vitreous involvement, and very good final VA, and no more skin rash. So it's very important to examine the patient. Here's another case of 41-year-old male patient complaining about decreased VA, and also with 2100 of vision and an anterior chamber reaction. Here you see right and left eye. When we see the left eye, we can notice this change here in the macular region and the nasal lesion. So when we ask for autofluorescence, we can see this hyperfluorescence, which we performed OCT, no change, but we found some fluid and OCT close to the optic nerve. And here is the answer. Syphilis serology positive, patient treated for with ceftriaxone for 14 days. Ceftriaxone is an option for the treatment of syphilis, and the final VA was 2020. So, and here you can see the recovery, like much better, no more hyper fluorescence, and a huge, no more fluid, and a very good improvement. So this case is a very, very interesting case because it is a 45-year-old male HIV high myopic patient complaining about decreased VA one eye for 3 months. He was complaining about floaters in the right eye, and he was treated previously with antibiotics and oral steroids for sinusitis, but he was very good. He was pretty well for the HIV, no opportunistic infections at all. And at that first time we evaluated the patient, he presented 2200 and 2040, anterior chamber reaction, both eyes, normal IOP. And here you can see this changing in the ellipsoid zone. As you can note, see here some inflammatory material in the macular region. So we asked for all serologies and all negative. The patient keep worsening of the VA. We noticed the bilateral papilla edema, and the neurologist right away started post-therapy with steroids. But I was really not happy with this because he was receiving oral steroids, was treated with steroid, and it's getting worse and worse and worse. So I asked for new exams and also ERG and PPE, which was very unspecific, only made the diagnosis of neuropathy bilateral. And I was really thinking about what it is, what has happened with this patient. So then we ended up. So syphilis came up positive, and the patient was treated with ceftriaxone for 14 days with oral prednisone and presented with a very good improvement. But he presented with retinal detachment. I think it's related to the high myopia and not to the syphilis involvement. And we performed the surgery, and patient is okay with 20/20 vision both eyes. So this is another case of a 58-year-old male patient with decreased VA right eye. And here you can see this vitreous involvement. He was sent to neurologist and neuro-ophthalmologist evaluation, and then he came to our clinic, and this is a very important exam right now, and we found this change in the macular region. And as you can see here, we see this changes in the OCT as well, and left eye was normal. And again, syphilis serology was positive, and we end up with the diagnosis of posterior precoid maculopathy, and we treat the patient with IV penicillin, and look, 20/20 vision both eyes. So this is the very, very interesting case, because this patient came to us complaining about acute decreased VA both eyes and behavioral changes, and the history was he was vaccinated for COVID-19 with 2 doses of vaccine, but he said that the vaccine was expired, so he was like saying, "Oh, I got the expired vaccine. What happens with me? I will die. I will go blind." And so, and before he was seen by a neurologist because of the behavioral changes, and then he was referred to our service. So at the first time when we examined the patient, he presented with 2400 VA and no other changes. And here you can see like this change in the optic nerve, so very unspecific. He was treated before by neurologists with post-therapy. And here you can see no big changes in the OCT for the optic nerve, just thickness of the ganglion cell layer. Here is the visual field of the patient. And we were here like post-therapy for 5 days, high dose of prednisone oral for 2 weeks, and no improvement. So he came with the diagnosis of bilateral optic neuritis secondary to COVID vaccination. So I was not happy with this diagnosis. So we keep trying, and the patient just came to the office and asked one very interesting question. So, doctor, could you please keep a secret? I said, yes. And here is the secret. He had a new serology for syphilis, which was positive. He was admitted to the hospital, treated with IV penicillin. We maintained the steroids, and here's what happened. He ended up with a vision of 20/20 both eyes, no complaints, and no behavior changes. So I just want to summarize saying that not everything seems to be what it is, and not everything is what seems to be. It is syphilis. So, and as a take-home messages, I would say that syphilis is always to be considered as a differential diagnosis in uveitis. All suspect cases we have to perform the second exam. We have to repeat exam. We have to avoid immunosuppression if we have not confirmed the diagnosis. And ceftriaxone is an option, but 18% present with recurrence. So I would like to thank my colleagues to do this lecture and to take care of these challenging cases. And I would like to thank the IUSG for the opportunity to share the cases with you. Thank you.
Christina, those were very, very nice cases. I'm always surprised with how quickly patients respond to treatment when we make a diagnosis of syphilis. And I think, this is one of the big messages you're giving here. It looks terrible, and yet you treat, and then they get better and recover vision. And I think, the importance of retesting can't be stressed enough, particularly if things don't seem to be going the way you think. What seems to be negative initially might be positive within a few weeks. So, great cases, a very nice presentation. Our next speaker is Francesco Picci, and as you all know, he lives for imaging in different areas. Anything having to do with retina and imaging, he certainly understands very well. And he's going to tell us more about what we should be doing with regards to imaging for syphilis, and what are the key points when we're doing so.
Can you see my slides?
Yes, Francesco.
Perfect.
Yes, we can.
I thought the introduction was going to be he lives for syphilis, but thank goodness. And we can summarize this talk with this take-home point. Can we use imaging to diagnose syphilis? No, we can't. It's very easy because syphilis is the great imitator. Just to pick up where Dr. Pavese left, Italy is very involved into the distribution of syphilis in Europe, because not only we were the one to name it after Syphilus, who got the disease, and it was Girolamo Fracastoro who actually named the disease, but also we were the ones naming it the French disease. Dr. Pavese said that every European country, they named the disease after the people they liked the worst. But of course, we have nothing to do at all with syphilis, with the spreading of syphilis in Europe, because Italians, they behave very correctly and everything. So forget about this. Let's move on to the real stuff. Syphilis is indeed the great imitator, the great masquerader, but I'm a person who looks for pattern, especially dealing with imaging in retina and uveitis. So the question for this talk was, can we use imaging to group syphilis into particular patterns that can give us a hint that this is actually the diagnosis we're looking for, and then we can drive our laboratory testing towards that diagnosis. So what are the posterior manifestations of syphilis based on imaging? We will talk about four of them. One is the presence of the superficial retinal precipitates that Christina showed in one of her cases. Multifocal retinitis is something I've never seen, thank goodness, but it is indeed out there, and we will talk about how we should not use steroids without a proper antibiotic coverage. Retinochoroiditis, with the more retina involvement and lesser choroidal involvement, is one of the most common posterior presentation of syphilis. And then, of course, whenever the nerve is involved and there can be also accompanying neuroretinitis, then we should suspect syphilis. Let's start with the superficial retina precipitates. This is an HIV patient with a CD4 count of 200. PCR negative for the herpes viruses, and he's RPR positive. Now, you see all these white areas with this kind of ground glass appearance, and on top of them, you see small dots. There are dots on top of the retina, dots on the posterior hyaloid. So the presence of this superficial retina precipitate should make us think of syphilis. It's not diagnostic of syphilis because you can find it in toxo sometimes, you can sometimes find it in some viral diseases, but they should point you towards the right diagnosis, especially if they're associated with this ground glass appearance that we'll touch upon a bit later. They were first described by this group, and it was Emmett who gave the name. And if you ask Emmett again, he said that if he had to write the paper again, he wouldn't call them precipitates because there is not anything precipitating actually. They're probably accumulation of white cells, and they don't involve the underlying retina. Let's move on to the second pattern. The second pattern is a retinitis, which we call multifocal. So the lesions are intraretinal. This is always associated with the use of corticosteroids, whether systemic or intravitreal, without a proper coverage of antibiotic therapy. It's been described initially by Andre, David Raff, and Emmett, and then in multiple case series later. You can see that the multifocal retinitis appears white and punctate, and it involves the inner retinal layers, probably not extending towards the outer retinal layers, but it's not the precipitate that we were seeing before. So when you have this appearance in a patient who's been treated with corticosteroids, always suspect that the patient can have a syphilis which is not properly treated. Moving on to the most important posterior manifestation of syphilis, it's retinochoroiditis. It involves more the retina and lesser the choroid. And there are two types, the confluent and the placoid. Let's start with the confluent. The confluent can be divided based on the degree of white. Let's call it the degree of white of the retina. You can see it on the left side of the screen. This white is the one we were seeing before, this ground glass appearance, which is very different from the dense white that you see in herpes virus or in toxo. And frequently there are a lot of precipitates on top. So this is the ground glass appearance of the confluent retinochoroiditis. Now there's also a denser appearance. Now here, looking at this patient, you would think first of other diseases, not syphilis, because the white is much more dense. It looks more like acute retinal necrosis or toxo. So the ground glass appearance have some particular features in imaging and in the dilated fundus examination that can point us toward this syphilis appearance. First of all, ground glass because the retinitis is not as dense as herpetic retinitis, for example. It has always this triangular shape. And if you do a fluorescein angiography, you have associated vasculitis, and you have hyperfluorescence of these triangular margins. And as I mentioned before, superficial retina accumulation are most of the time associated with this ground glass retinochoroiditis. This is a patient, you can see in the ultra wide field image, you can see the dots, the accumulation, the precipitates if you want, but you can see them much better in the normal color picture, non-wide field color picture. The second type of retinochoroiditis is this one. I think this is something we have all seen in our practice, and it's characterized by a white plaque that always involves the macula. It's hyperautofluorescence, we will check why in a second, and it has this particular RCT appearance with the ellipsoid zone disarray and RPE nodularities. So this is the posterior placoid chororetinitis, what Gus first described, calling acute syphilitic posterior placoid chororetinitis, or ASPPC. Now, what are the characteristics of this placoid retinochoroiditis? First of all, the white plaque involved in the macula. Why does this white plaque involve the macula? Well, because if the spirochete comes towards the choroidal stream, then the choroidal flow is much, much higher at the level of the macula. That's why it mostly involves the macula. In autofluorescence, you got these dots of hyperautofluorescence. Why? Because the RPE, as we saw before, and we will see again, the RPE is affected and creates all these nodularities, and these nodularities, they are hyperautofluorescence. In FA, there's a hyperfluorescence of the margins that comes late during the exam. And in ICG, there is hypofluorescence. And we will see again, only through the use of OCTA, we've really understood why there is hypo in ICG. The most important exam to suspect placoid retinochoroiditis, it's OCT. Now, if the patient is lucky enough to come to you with the decreased vision and a very recent infection, you can see the subretinal fluid in the first few days of the retinochoroiditis. But then this fluid goes away on its own. You don't have, I mean, you have to treat the patient, but whatever you do, the fluid goes away on its own. And then by the 7th day, you get all these nodularities. You saw it in a case that Christina presented as well. These RPE nodularities with associated loss of ellipsoid zone, they're nearly always telltale of a placoid syphilitic disease. And then if you start the proper penicillin therapy, there is a complete restoration of the ellipsoid and the RPE goes back to normal. Why was ICG hypo? Through OCTA, we have seen, and we have actually at this point proved that this placoid form is a retinochoroiditis because the chorocapillaris is indeed a bit involved. You can see it here, that there is an area of flow void at the level of the chorocapillaris that with the proper penicillin treatment goes away. There is restoration of the flow of the chorocapillaris. So this is the reason why hypo on ICG, and this is the reason why we can say that actually the choroid and chorocapillaris, they are involved a bit. Finally, whenever you have involvement of the nerve associated more or less with subretinal fluid, then you should suspect syphilis, as long as many other infectious or non-infectious diseases. Now, when there is a papillitis or neuroretinitis, always consult your ID specialist, but my ID specialist always say that we should test VDRL in the cerebrospinal fluid. That's the only test to use in the cerebrospinal fluid. Positive results confirms the diagnosis and helps you guide the treatment. Now, what are the take-home points of all this? Now, try to use imaging to search for your posterior pattern. Use mine as well if you want, and so you get an idea what to order, because this is more rewarding because you get the idea this could be syphilis, you get the confirmation, is also less expensive for your institution. Again, I'm sure we will touch upon this, the traditional algorithm and the reverse algorithm. So the way you test for syphilis can change slightly based on where you practice and if you're in a low prevalence population with syphilis or high prevalence population. And of course, treat always as neurosyphilis. We will hear Dr. Goldstein talk about this. And with this, I thank you very much for your attention.
Thank you very much, Francesco. Maybe you can give some thought to the following, but we just heard in the previous talk that you have some other forms, for example, Bigel and Pinta, and you're in a part of the world where Bigel might still, I know it's more in Saudi Arabia, but maybe you see some cases also where you are. Are there differences with regards to the imaging that you would see, or can it be useful in those cases?
So honestly, I have not noticed a difference between when I was in the US and here. Of course, here in the UAE is much less prevalent, but there's a big community of expats. And I just had 2 weeks ago an expat presenting with that triangular shape, retinochoroiditis with the granulous appearance. And as soon as I saw it, I kind of got an idea this could be syphilis. So honestly, no. I've seen here triangular, I've seen placoid. So more or less the presentation is very similar in the posterior part of the eye.
Okay. We'll go on to the next talk. Thank you very much. I think it's a very good review, and even though you say imaging doesn't serve any purpose, it certainly seems to be useful in the follow-up of patients. So I disagree with your original comment. Our next presentation is by Rina, which is going to talk to us about the laboratory investigations. So I give you the floor, Rina.
Okay, thank you. And I would like to thank you, Prosmet and Prof. Shali, for inviting me in this wonderful session to talk about the laboratory investigations in ocular syphilis and its challenge in interpretation. So as we heard from the previous talk, it is the great masquerader. So prompt diagnosis and treatment are vital to prevent blindness. And there is a crucial role of diagnostic test here. Ocular syphilis may occur during any stage, but it typically occurs with secondary, latent, or tertiary syphilis. And there's a Delphi consensus. Most of the International Ocular Syphilis Study group members perform syphilis lab testing in every patient with uveitis. There is no single optimal test. The diagnostic laboratory result will depend on the patient disease stage at presentation and the type of test that we use. As general, we can divide the laboratory testing of syphilis to direct method or serological method. And there are plenty various of type of tests that we can do. And the result and the choice differ according to the type of serologic test and the disease stage. For primary and secondary, we can think about the direct method where dark field microscopy will show the treponema pallidum directly, but negative results do not exclude infection. But for inocular syphilis, we mostly use serology. Therefore, I would like to show you what kind of antibodies detected in the serological test. This is the treponema, and we can see that in the treponema, there is a treponema-specific antigens, the green one. And also, when it infects human cells, the cells will excrete lipoidal antigens, and there will be also antibodies toward that lipoidal antigens. So we detect the anti-treponema antibodies that is specific for the treponema that we call treponema test. And also we try to detect anti-lipoidal antibodies that we call it the non-treponemal test. So the non-treponemal test, I show you two examples, the Venereal Disease Research Laboratory and also the rapid plasma reagent. They try to detect the immunoglobulins produced in response to lipoidal material released from the bacteria or the dying host cells. The difference is they both have antigen, cardiolipin, but one, the RPR is coated to the charcoal particle. And this antigen then mixed with the patient's serum that could contain IgE and IgM towards cardiolipin. And then we can see the flocculation. In federal, we have to see it by microscope, but in RPR, we can see it directly with the eye. So principally, the antibodies to lipoidal antigens are usually not detected until approximately 6 weeks after infection. Therefore, it has limitation that it has reduced sensitivity to primary or latent syphilis. But the advantage is it is rapid and inexpensive, and we can evaluate treatment response because in reinfection or treatment failure, we can see a 4-fold increase. And if we have an effective treatment response, we can see a 4-fold decrease of the titer. And the titer decline over time and may become non-reactive with or without treatment. We have to be careful with the false positivity. It could be false positive in other infection because it is detecting the non-treponemal antigen if there's a cells destruction, or there is a false negative due to the prozone effect. This is usually because the antibody titers are very high, so it doesn't form a positive flocculation test. in this instance, we can ask for the dilution of the samples, so we can have the good zone of equivalence, so we can detect the flocculation. And this is the treponemal test. The treponemal test, the test tried to detect the antigen of the treponemal pallidum. And when it is mixed with the patient's serum, it can happen, there is an agglutination. The difference between TPHA and the TPPA is it is a similar treponemal antigens, but it is coated by gelatin. So it will hinder no specific blood plasma reaction. This is the example of the agglutination. If it's there's no red dots, it means there's an agglutination. And it is very sensitive, especially in secondary, and it is specific in all stages. But the limitation is it is remain positive for life. Therefore, we cannot use to evaluate treatment response and reinfection. And it needs a standardized tools, laboratories, and technician reagent should be kept in chillers. Therefore, it gets quite high cost and difficult to mobilize, especially with area with limited testing. But it has a high sensitivity and specificity for all syphilis stages. This is another example of treponemal test where we use fluorescein microscope. It is staining the treponema directly, and it is really sensitive and specific too. The advantage is it is most sensitive serological test in the early stage of syphilis, but the limitation is there is a subjective interpretation, and we have to use a fluorescent microscope, so it is not applicable in limited setting. So there's an algorithm. Previously, we used a traditional algorithm where we check first the non-treponemal test. When it's positive, then we continue with treponemal test. If it's negative, the syphilis is unlikely. But if we can see if the non-treponemal test is non-reactive, it is not necessarily that there is no syphilis. If the treponemal test is still non-reactive, there is possible it is a very early syphilis before it became converted serologically. And if it turns out the treponemal test is reactive, it is a prior treated syphilis and it is an untreated syphilis. So people are trying to do the reverse algorithms, and also maybe this is the European group test that they will confirm with another treponemal test after the positivity of one treponemal test. But among the ophthalmologists from the current ophthalmology practice that is observed by the International Ocular Syphilis Study Group, among all ophthalmologists, they like to do both tests, since the non-treponemal test can be falsely negative, especially early or late infection stage. Therefore, it is good to perform simultaneously both treponemal and non-treponemal tests. More than 50% ophthalmologists get it. So what about the direct method? For example, the dark field microscopy, silver staining, or immunohistochemistry. It is quite difficult in ocular syphilis because of the inability to get the samples from the eye, and also the difficulty in the technique in the lab. So I will try to share about the PCR, because the artificial culture so far is still in the research base, so we cannot yet really culture the treponema pallidum clinically. So the nucleic acid amplification test can be used. It can be from many samples, the skin, anal, or even from the ocular test. It can be used of various methods, classic PCR, nested PCR, quantitative PCR, and there are gene targets that is already studied, and it is quite useful. The advantage is the specificity is quite good, and it is highest sensitivity in primary syphilis, and can be used also to detect antibiotic resistance. But the limitation is other samples will have different kind of quality of the positivity rate, and it is low sensitivity in secondary and latent syphilis, where ocular syphilis mainly reside, and it is an expensive method and required a high-skilled technician. So in many literatures, it is found that Treponema pallidum DNA detection in ocular fluid sensitivity and specificity is still not clear. There are studies about using the PCR from vitreous, and also probably the using to use treponemal test from the aqueous humor. But it is not common, and also from the study from the International Ocular Syphilis Study Group found that around only 10% of the ophthalmologists use the direct method by using PCR from the ocular fluid. Maybe in my last minutes of presentation, I will touch upon several topics: neurosyphilis, HIV, and also other non-venereal syphilis, and about recurrences and antibiotic resistance. So what is the relation between ocular syphilis and neurosyphilis? In almost all guidelines, in all diagnosed syphilis, we have to identify visual, hearing, and neurologic symptoms. If positive, do a cerebrospinal fluid examination. And also in the International Ocular Syphilis Study Group, around more than 90% of the ophthalmologists perform CSF examination. What do they expect from there? They try to look for the federal and TPH positivity, the cell count, and the protein level. And even 1/3 of the ophthalmologists considered that the presence of intraocular symptoms alone or ocular syphilis is sufficient to be considered to be the diagnosis of neurosyphilis. What about HIV and AIDS? Although there is no strong correlation between HIV status and treatment failure and visual acuity outcome in ocular syphilis, double infection is very frequent, and delays of more than 28 days from visual onset to the treatment in this group of patients are associated with worse visual prognosis. And also the standard treatment for primary syphilis in patients with co-infected with HIV may result in treatment failure, progression to neurosyphilis, and possible ocular syphilis recurrence. Therefore, every time you see ocular syphilis, it is good to check also for the HIV. And we should suggest that sexual partner do the same exam and see whether they need the treatment also. So is there non-venereal syphilis? In the endemic treponemal disease consisting of Yos, Bejel, and Pinta, it is closely related to syphilis, and WHO classified it as neglected tropical disease. The current serological technique, though, cannot distinguish infection with syphilis from non-venereal trypanosomes. Therefore, the interpretation of the serology depends on the understanding of the epidemiology and clinical manifestation of each disease. What about the reinfection? There is always a risk of reinfection even after receiving the standard therapy. People with who experience reinfection will have signs of symptoms that recur or have continuous fourfold increase in the non-treponemal titer. So how do we diagnose that? We can find a 2 times increase in the titer in the RPR plus a positive treponemal test or the positive treponemal pallidum PCR. And that is followed a previous episode of syphilis. So there was syphilis, it is already cured, but then there's these 2 criteria happen in that patient. What about IgM? So IgM detection was not a sensitive method, both for diagnosing syphilis and even poorer in the diagnosis of the syphilis repeat infection. So we cannot use this kind of test. So what population are at high risk for reinfection? There's a study found that the HIV status and also the frequency of condom use is significantly associated with treatment failure and reinfection. And I will try to talk a bit about antimicrobial resistance. So this problem arises because there's issue about patient refusal in injection from the injection of benzathine penicillin because of the pain, risk of severe allergic reaction to penicillin. And there's a second-line oral antibiotic in treating early syphilis that sometimes people easily switch to that second line, or their usage for mass drug administration in Yos eradication effort. these possibilities, this factor might increase the antimicrobial resistance of pallidum to the second line of treponemal treatment, such as macrolides, azithromycin, and tetracycline. There's already a study that they do a genomic epidemiology analysis, and they found that there's an emergence of microlide resistance across multiple circulating lineages of the Treponema pallidum. How to diagnose it? So far, the possibility is through the PCR, and there are already some gene detected about for the azithromycin resistance and also tetracycline resistance. Probably that resistance is not a problem now, but something that we should think about. So in conclusion, the result of the serologic test vary according to the type of the test. Is it treponemal or non-treponemal, and also the stage of disease. And in ocular syphilis, please always perform HIV testing. Follow-up of serology is proper because we can see the efficacy of treatment, resistance, and also recurrences, and beware of especially the reinfection. So for us who deal with uveitis, if you do not know what it is, I think we should think about syphilis. And I also want to thank to my colleague in Indonesia, and I will end my presentation. Thank you so much.
Rina, thank you very much for a very, very comprehensive talk. I think it clarifies a lot of questions that have come up in the Q&A, and at the same time, I think you have some good elements for a discussion that will follow very shortly. The following presentation is on treatment, and it will be by Deborah Goldstein. Unfortunately, Deborah can't be present. It's time issues, of course, with the United States, and she pre-recorded her talk. So if we can have that presentation, we'd certainly love to be able to look at it.
This IUSG webinar, and hello. I am sorry that I am presenting this as a pre-recorded Zoom. Thank you for inviting me to be part of this IUSG webinar, and I'm going to round things out talking about the treatment of syphilis. I don't think it'll take 15 minutes because it's a one-word answer: penicillin. So I have served as a consultant or received research support from AbbVie, Bausch & Lomb, and Allergan, but these are all irrelevant. My interests in syphilis are purely academic. So we treat ocular syphilis as neurosyphilis. So any intraocular involvement with syphilis, even if the patient otherwise has secondary syphilis, is treated as neurosyphilis. And the CDC recommendations are for aqueous crystalline PenG, 18 to 24 million units per day. This can either be given as a continuous infusion or split up as 3 to 4 million units IV every 4 hours. And this is for 10 to 14 days. Most of us use 14 days. When I trained, the patients had to be admitted to the hospital for 14 days for this treatment. Nowadays, most of the time they come in for 1 day, get a PICC line placed, and go home with a pump. There are alternative regimens. We can use procaine penicillin G, 2.4 million units IM, once daily for 10 to 14 days, but this has to be administered with probenecid, that's 500 milligrams orally 4 times a day for the entire duration. It's very important to know that we can't use macrolide antibiotics like azithromycin, clarithromycin, and erythromycin because there are resistant strains and strains with high level resistance prevalent in many developed countries. So really the recommendation is that if a patient is truly panallergic, that they be admitted to the hospital and have penicillin desensitization. So what I find very interesting is that the first reported cure with penicillin was in 1943. And while we have penicillin-resistant staph and strep and every other organism in the world, we still don't have syphilis that is resistant to our first antibiotic. So what about response to treatment? So the question is always, how do HIV positive patients do with treatment? And we've heard by now that when we diagnose syphilis, we need to test for HIV. And there was a very nice series of 96 patients with ocular syphilis or neurosyphilis, and half were HIV positive. And there was no difference in treatment response between HIV positive and HIV negative patients. What about Yarek-Hersheimer reaction? This is an exuberant inflammatory response. Classically, it is thought of as dermatologic findings and systemic findings, but we can also get a marked increase in vitritis, vasculitis, and macular edema. This typically occurs within the first 24 hours and usually in the first 2 to 8 hours after initiation of IV penicillin, and this we manage with the addition of oral prednisone as needed. So what is the response to treatment? Well, in terms of blood testing, we want to see a 2 dilution, in other words, a 4-fold decrease in the RPR or the VDRL. So a 2 dilution, 4-fold decrease in non-treponemal titer, and we want to see resolution of clinical signs and symptoms. And actually, that's what I look at. Infectious disease does look at serology. I look at treatment response. The question arises at HIV positive patients, and sometimes we see that although the titers go down by 4-fold, they'll still stay positive at 1 and 2 or 1 and 4 and 1 and 8. This is called a serofast state, and we don't know if there's any biologic significance to this. So I'm going to show you a couple of cases. I can't help it, but I will show you a treatment response in 2 patients. The first is a 36-year-old male who had balance issues and decreased vision in his left eye. And you could see this beautiful photograph showing something going on here in the retina, more easily demarcated with the autofluorescence. And as Dr. Peaky showed you, this is very characteristic OCT with loss of ellipsoid and these little pyramidal excrescences on the RPE. So our clinical diagnosis here was syphilitic placoid retinitis. We did the workup, FTA positive, RPR was positive, lumbar puncture was positive in terms of the VDRL being positive, and he was HIV negative. He was treated with aqueous crystalline penicillin G. He actually got 24 million units divided Q4 hours. And here he is after 3 months of penicillin. We no longer see the yellow infiltrate in the retina, and you could see here that the ellipsoid has recovered, and in fact, his visual acuity recovered to 20/20. My second case is a 61-year-old male with non-Hodgkin's lymphoma who's being treated with systemic chemotherapy. And he presented to an outside ophthalmologist with blurred vision in both eyes. He was found to have some anterior chamber cells who started on pred acetate 4 times a day. He was evaluated by a retina specialist who was concerned for lymphoma. At this point, his vision was 20/50 and 21/50. He was started on 60 milligrams a day of prednisone, had an MRI brain, which was normal, and a lumbar puncture, which had no B cells and no T cell abnormalities. So here's the photograph that you see. This is from the referring retina physician, and you could see these beautiful placoid infiltrates. So you guys all know that this is syphilitic placoid. Here is the autofluorescence, clearly delineating the areas of involvement. And here is the very characteristic OCT. Unfortunately, the diagnosis was not made at this point. He was evaluated by an outside uveitis specialist. There was a concern for acute retinal necrosis. So prednisone was tapered and valacyclovir was started. He also had a diagnostic vitrectomy at this time, which showed scattered degenerated atypical lymphoid cells, and he was referred to the uveitis service at Northwestern. At this point, his visual acuity has decreased to 2500 in the right eye and only light perception in the left eye. Intraocular pressure was normal. There were diffuse fine KP in both eyes. He had a very significant anterior chamber reaction, 3+ cells in the right, 4+ in the left, and 4+ anterior vitreous cells in both eyes. And you could see here on the right that those isolated placoid areas are now almost confluent. And here we see more of what looks like full thickness necrosis rather than placoid outer retinal involvement. Here we can see some preretinal infiltrates and even what looks like a preretinal hypopion. And the left eye is more significantly involved. There is more haze and a very infiltrated looking retina. Here is the OCT. The posterior pole still shows us loss of ellipsoid and these pyramidal excrescences. But if you see the OCT from the peripheral area, you could see that there is now full thickness necrosis. We do not expect recovery of those areas. And this is likely because of not only the delay in treatment, but the fact that he was on chemotherapy and then had an additional 60 milligrams a day of prednisone. So our diagnosis, obviously syphilitic retinitis, RPR was positive, TPPA was reactive, and HIV was negative. So we stopped his Valtrex and we treated him with 4 million units IV Q4 hours of aqueous crystalline penicillin G. And here he is with 3-week follow-up after completion of his 2 weeks of therapy. You can see that the vitritis has resolved, the retinal infiltrates have resolved, and his visual acuity has responded really well with recovery to 2025, and 2060. So what about treatment? Again, the only antibiotic that is currently recommended by the CDC for treatment of all stages of syphilis is penicillin. And to date, we have no documented penicillin resistance. But if something were to happen with a mutation that conferred resistance to penicillin, there could be disastrous consequences. Thank you so much. And I appreciated being asked to participate.
We now have time for a discussion. I think there are a lot of elements that were brought up, so I'd like all of the speakers to come online. And does anybody have any specific cases they wanted to show, or any comments at this stage with regards to the presentations that were made so far? Maybe Carlos, do you have any comments?
No, thank you, Mark. This was a really great session. Thank you all for sharing your experience and cases. And I think what's very important here, highlighted especially now in this final presentation by Deborah, is that syphilis, the outcome can be very good, but it depends on you making the diagnosis and acting quickly on it as well. So if you really delay, and for reasons you can see here, a patient with an underlying problem that was probably making the clinicians more uncertain about what was going on, thinking of the lymphoma, thinking potentially of a viral infection. So there was a huge delay. So the progression from the simple changes we see, as I always tell the people when I'm discussing imaging, and Francesco can correct me if I'm saying something incorrect here, but I always mention to them, if you see these abnormalities in the ellipsoid zone, it looks very abnormal. This is not a histological section, doesn't mean histological damage. It simply means that the light reflex coming from those layers has been altered by an inflammatory process or something that's making it look different. The reason why they recover is because they're not destroyed. If they had been destroyed, they wouldn't be recovering. They wouldn't go back to normal. So they're recovering because whatever happened, it changed the way the image is produced, what the OCT is showing you, but it means it's just a rearrangement. It's just a question of you getting rid of the insult and then allowing the tissues to recover and function as well. So I think it's a good message that think syphilis, as you've heard from everyone, always think it because of there's many different ways in which it can present. There are some presentations which tend to be very, very telling. You look at that, as Francesco said, he looked at his patient and he immediately thought syphilis and had just to confirm. The same happens with Vishali. When you look at your Serpiginous cases, you think of TB. So we have some presentations which are very suggestive, but there are many other presentations which are not classic, but they can very well be produced by conditions like that. And I just to share with you, I had one patient who was showing this recurrent anterior uveitis, no signs of posterior disease, and we ended up finding the spirochete in his aqueous. So we took a sample from the eye and did the analysis, and he had spirochete in his aqueous humor. So it is one of those situations when we suspected it because of other factors, history, and confirmed the diagnosis. So it is a high level of suspicion, a knowledge of the typical things that you think about in syphilis, but also remembering that even if not typical, you still have to think about it and test. And what you heard also from Rina as well, the issue of reinfections and the importance of retesting these patients. and treating them again. So I think, yeah, the big message is there, is think about it, test, and treat quickly.
And I think you bring an important point, because most of the images we saw in the presentation all show us posterior pole, and that's the one where we might be able to see the patient. That's why they're referring to us. But if you look, at least in the Western world, probably half of the cases are anterior segment uveitis, and somebody mentioned that earlier. And we, it's not the first thing we'll think about if we see somebody with anterior segment uveitis. There were a few questions, I think, that were interesting that came up on one or two occasions here in the Q&A. And one is...
Francisco has his hand up, Mark. Francisco, his hand up.
I just have a question for the panelists. So Dr. Goldstein mentioned the decrease in the RPR. So how important it is for you who treat syphilis, and are you the ones following as ophthalmologists? Are you the one requesting it? Like, for example, a month after treatment or 2 weeks after treatment. And so, especially because patients maybe are not hospitalized, they come with a PICC line. So just picking your mind about it.
Can I just say what I do, Mark, and then you pass on? My patients are usually referred to a unit where they look after sexually transmitted diseases. So the management is in their hands. What we do, as Deborah was saying, I'm more basing my satisfaction in the clinical response. So if the patients are showing reversal of the clinical findings, responding well, then I'm happy they're responding to treatment. But I leave the decisions regarding other aspects of the treatment to the group of the infectious disease center where they are managed. So I'm usually not involved in those decisions, but I can see that in some places maybe you have to. But this is my experience here.
I would say about the same, is that in my experience, if I make the diagnosis, I ask the infectious disease specialists what they want in terms of treatment and what is more appropriate for the particular setting, having gone to many places during my career. But I think, one of the messages here is if these are patients that are at high risk of recurrent infections, we should probably get at least a measurement so that we have it in our own charts, so that we know if there is a VDRL increase, that it is representing a 2 times increase or more, and we should be thinking about a reinfection. What about the use of steroids? You have a patient that has all of this stuff inside the eye. Should we use steroids? Is it ever necessary, or can we be, happy with the response to treatment? Any comments?
Well, I'll very quickly say I think steroids are really important in especially when you're beginning specific treatment, because you're likely to have an increase in inflammatory reaction as a response to therapy. So I think it is has an important place in this, and will help prevent further deterioration because of treatment reaction, but also helps accelerate the resolution of the inflammatory response that you see before. So in my practice, yes, I would say yes, it's an important role, and I do use it.
And do you use topical, systemic,
I would say it's systemic, yes, because of the drug reaction depends on systemic. Topical, of course, it depends on the presentation. If the anterior segment is the problem, then yes. But I tend to add systemic therapy very quickly for this patient.
Vishali?
If I may ask, there is a question related to steroids. Like, if you have a patient with HIV, where you are expecting more of worsening on therapy, would you be inclined to use steroids more versus another setting? So are there any particular conditions where you would definitely add corticosteroids? This was the question asked, which Christina has answered, but it's nice to have panel's opinion.
John, you have raised your hand. I don't know if you wanted to talk about steroids, in which case you might as well give your answer to Vishali also.
I really don't have tons of experience. I would sort of approach it similarly to other kinds of retinitis that I was treating with anti-infectious treatment and then adding steroids to try to suppress the inflammation. So.
The Herxheimer reaction isn't all that frequent. It is certainly a concern, but my approach with this would be, depending on how severe it is. If it's a very bad retinitis, you should probably cover it. But if it's not too severe and you have the placoid, I would probably start the treatment, follow the patient, and then after that, see if it's necessary, I'd introduce the steroids after. But Christina, you had such wonderful cases that you showed. What would you do?
Christina is typing the answer.
Hi, Mark. I was answering one question. So could you please repeat your question?
So the question is you have your patient with some degree of inflammation inside the eye. Some of the cases you showed, you diagnose syphilis. What do? Do you put them on steroids, or when would you put them on steroids? Do they all go on steroids, or do you select your cases?
Well, I use steroids a lot, so I have no. That's one of the questions that I was answering right now. I don't see any problem to use steroids for syphilis. So I think if the patient needs like a decrease VA, vitreous involvement, very aggressive lesion, and very aggressive vitrites, I think we have to. I don't see any problem. And if you remember those cases, I presented 2 cases that the patient received previously by the neurologist because the patient was seen only by neurologist. He came with pulse therapy, and of course, he didn't improve, and he started to get worse after that. So, but it is important to give the right therapy. As you said before, we cure syphilis, so it's very important to make the diagnosis and the treatment right away. So that's my experience. That's our experience here at the university.
There was also a question with regards to what do you do if a patient is on steroids, and you've just mentioned it now. Do you continue with the steroids? You increase the dose? What do you do when you introduce your penicillin treatment?
Well, I continue with the treatment with the steroid. Even when I finish the 14 days of penicillin, sometimes I do continue with the steroids alone until the patient presented with a completely with no inflammation, recovery of the inflammation and the VA. So that's our experience. So we have no problem to treat syphilis with steroids.
Okay, Vishali?
There is a question from Yale who says, would you wait for 48 hours before starting steroids?
Any comments? Christina, would you wait with treatment until your penicillin has started functioning, or you would start right away?
Right away. No, I don't see any reason to wait for it. Yep.
Carlos?
Mark, actually, the point is the center we refer our patients to usually give the patient 3 days of steroids even before starting the treatment. So they are already doing that as because of the reaction risk. So they already start the patients automatically on steroids. So it may be that we are needing the steroids anyway, which is mainly most of the time is the case. But even if we're not mentioning the steroid, they automatically do that. So I agree with Christina's view that we tend really to probably prolong even the steroids depending on the response. So the treatment is really important because it stops the infectious process, but the inflammatory reaction is still sometimes going on, and you need to make sure that you remain on top of that until the situation is fully controlled. So I don't have many concerns about steroids in these patients also.
Okay, very good.
Just give it one more opinion. I agree with Carlos, of course. That's the same what we do here, but I just saw a patient yesterday. Unfortunately, I didn't have the complete case to show you, but the patient was admitted to the hospital, treated for neurosyphilis, and then after the treatment developed eye symptoms, and this patient started by himself taking 80 milligrams a day of prednisone. I saw the patient yesterday. He has the most impressive acute retinal necrosis that I've ever seen in my life, bilateral. So that's another point. We have to keep an eye on the patient. We have to be sure that we treated the patient. So that's another, just to to give a little scare time about steroids and don't follow the patient.
So careful follow-up's important. John?
So epidemiologically, there should be some cases that are, maybe they've had syphilis before and they just have normal uveitis, but they will test positive. And I think we've seen a number of cases that are very strongly suggestive, and especially in the posterior cases. But if you have sort of just acute anterior uveitis that's a remitting case, you, I guess, probably should go ahead and treat it like was recommended, but you might not always cure it if it was sort of a false positive. Not false in the sense that they didn't have syphilis, but just false in the sense that it wasn't causing uveitis. And I'm just curious how people approach that. Like if people are having this sort of, low pretest probability test, it comes back positive, they treat, and then the patient relapses later. Are you going to be concerned about syphilis then, or are you going to just say you've taken care of it and you'll just treat it like uveitis? So I bet you there's heterogeneous answers, but I'm curious what people would say.
Maybe Vishali, you had the point, and then after that, Rima?
I'm just looking at the questions simultaneously. There are two questions by Dr. Feldman and Dr. Kumarasamy, and they're very genuine questions. What if penicillin is not available? And we are having this problem recently that penicillin G is just not available. So they want us to discuss about alternate therapies in detail.
So maybe I'm not answering Dr. John Campan yet, but I want to contribute to the discussion of what Francesco asked before about who's going to check the laboratory result after the treatment. And I agree with Dr. Carlos and Dr. Marsmet that we collaborate with the infectious disease or the dermatologist in this instance. But I think we should have the data because nowadays we have, in my practice, I experienced many HIV-related ocular syphilis that came again with inflammation. So I think we should know about whether it is a reinfection or it is not responsive to treatment or other, because in HIV patient, there's a risk factor that they can have a reinfection. And second of all, about the alternative of treatment, in Indonesia, we don't have the aqueous penicillin, and also we don't have the procaine penicillin that supposedly can enter the blood retinal barrier or the blood-brain barrier. Therefore, together with our neurologists, we think about the alternative treatment, which is ceftriaxone, 2 grams for 10 until 14 days. In our experience in our clinic, it is much more responsive than just giving the benzathine penicillin, which the dermatologist given. I think that's our experience in Indonesia. Maybe plenty of other countries that doesn't have also the aqueous penicillin in their place.
Rina, I had another question for you because you mentioned in your talk that you do have some cases of cross-reactivity, for the non-specific test, in particular with TB. And what did you mention more? That you could also have it with leprosy and, for example, also with HIV. How often do you see that? Maybe this is a good question for you, Rima and Vishali. How often would you see a cross-reactivity, for example, with a TB patient?
For my setting, I didn't see that often, but there's always 1 or 2 patients that we got confused whether it is really due to syphilis or the cross-reaction, but it is not often, Mark.
Like in our clinic, we always test both for TB and syphilis, and we hardly have any syphilis positivity. In fact, it's once in a year or twice a year, and we get very excited if we get test positive for syphilis. Rima, I think, has something.
Yeah. So same questions I had. One was the alternatives for the penicillin, which if it is not available or the patient is not ready for hospitalization. So that's been answered well. There were a lot of questions about doxycycline in the question answer section. So What is the panelists' take on doxy? Because that's one drug which is easily available. And, if we don't have the option for penicillin, we can give that. Another question was, like we do, as Dr. Vishali said, we always test in each and every patient for TPHA, whether it's anterior or posterior uveitis. So I just wanted to know from the panelists, do you do in all your patients or only in your suspects?
So in our clinic, we do both the treponemal and non-treponemal test. That's in my experience.
Agreed.
Okay, and others?
Yeah, we do both also. I mean, that's the way I was classically taught also, although there are some people here in Switzerland that would only do a non-treponemal test as first instance, which I find a bit surprising. But the majority of patients I see don't necessarily have a recurrence. We also always test for HIV. So, and I think in our population, it's a given. If you look specifically around here, the majority of syphilis positive individuals are men, as was mentioned before, and among women, it's either drug abusers or people of the sex trade.
I think for me is the same. Sorry, Francesco, go ahead.
No. Talking about the other question from Rima, if penicillin is not available, I think I'm not sure about the evidence, but I think ceftriaxone should be the second line and doxy the third line.
Okay.
Yeah. Just the issue of the test, I agree, Mark. I think we're old school. I still order both at the same time. I don't do one first. I just go with both of them. And just going back to John's question about the anterior uveitis, John, that I think if you have a case that you highly suspect the behavior, like this patient I mentioned to you, was a very strange case because the way he was recurring and the treatment was partially working, the inflammation wouldn't really settle down in spite of frequent topical steroids. And then, of course, we get some history from the patient. So he became a suspect and we tested, he was treated. And I think if you talk about inflammation recurring, if you look at we were just talking before, you usually use your clinical response as a measure of efficacy of your response. But let's say you do that treatment and you follow the patient serologically and that the patient responded serologically well and the infection is being controlled, then it might very well be that just you have to do is treat the inflammation, continue to treat the inflammation from the eye and see what happens. I think normally I would expect that you might have just to continue a bit longer with your anterior segment treatment to lead to full control. It's a different situation if you think of reinfection. Here is too close to the treatment to consider that. So you just talk about the treatment of the primary problem you saw. So in this case, I'd say, if the test is showing response, which then indicates your drug is working, then I think I would say the anterior segment I'll treat with the normal treatment for anterior uveitis and just observe longer. Yeah.
Yeah, I think if you're going to follow an approach of, testing every uveitis patient, something like 50% of, in a tertiary uveitis setting, 50% will be anterior uveitis, and they wouldn't sort of be expected to be syphilis positive, but we have this idea that we ought to test them because even if it's only, say, 40 or 50% chance after the positive test, it would be worth it to cure them if you could.
Yeah.
But I think if it doesn't resolve and it doesn't seem like a very typical syphilis case, then I think you could just treat it as a normal uveitis.
Yeah.
After that.
Or the other hand, you think if it's not a typical anterior uveitis case, then you worry about syphilis. That's the thinking the other way.
Yeah.
If it's a typical behavior, a B27 behavior, something you treat and you see the response, but the syphilis cases will not respond in the same way. If the syphilis is active and the infection is going on, the response is going to be partial and it will immediately increase again. So you have a clue that there is something in the background which is not allowing that to settle down. So I agree with you. I wouldn't be testing every anterior uveitis. That many times the uveitis don't even test for anything. Depending on how they present, I just treat them if it's the first event, and then I decide to treat if something else is happening. But I wouldn't test every single patient with anterior uveitis that I'm not suspicious. But all other forms of uveitis, syphilis is part of our work in diagnosis. Yeah.
I think, if you look at epidemiology, because that's what you like also, John, is that the incidence in large series, at least in the Western world, are about 0.5 to 3% for syphilis overall. So you're not looking at high numbers. And if we were to look at anterior segment, it would still fall into that. We would have to reduce it by 50%. So yeah, I would first start by treating in a standard way. And if there's something that looks odd and it doesn't respond well, that's when we should test for syphilis and rule it out. Does anybody have any, I haven't looked at that for a while, I have to admit, but any thoughts about how to diagnose and manage in congenital syphilis? I guess we have to think about babies. That's the first things when they're newborns, or otherwise when they're diagnosed a little bit later, which is a bit of a different situation because then we have all the complications. Any thoughts?
I don't tend to see this kind of thing. The situation is usually ends up in the hands of the specialized units in terms of the infectious disease group. And I don't really have any personal experience with neonates in the situation of congenital transmission. So I'm afraid I cannot comment on that.
There is a question mark from Mamta. She says, you have treated it and the lesions are still active at 2 weeks. What would you do?
Well, first of all, if the it depends on, I guess, that I don't know, maybe we should ask Christina or somebody else first before I give an opinion on this. So you have a person that you've treated. Let's say that you're using IV penicillin. And what would you say if you were using, for example, tetracycline because you had nothing else in terms of choice? And at 2 weeks, you still have activity.
Can I answer for me?
Yes, Vishali.
Sure.
If it was tetracycline, I would want to get penicillin because I will give it a benefit of doubt that my antibiotic is not working. But if it is not responding to penicillin, I would doubt about my diagnosis and look for any coexisting or an alternative diagnosis. Yes.
Well, I would also check whether it's HIV because you might have a case that is more resistant and where you have to proceed with a longer treatment. And that was mentioned earlier too. In some cases, you treat longer. So if it were given intramuscular, again, you would bring up the same kind of discussion. Was it well absorbed? And should we go to another form? And for neurosyphilists, there were protocols in the past where you went straight to the CSF to be able to treat. So there are other alternatives that become more invasive. But I would agree, if it doesn't seem to respond, some of these lesions may be something else. It could be ARN, and we should treat in those conditions too. I think we're coming very quickly to the end of the session. And yes, John?
I just looked at the question about the congenital syphilis. So the CDC says you should treat with procaine penicillin G 50,000 units per kg intramuscularly with a maximum dose of 2.4 million units in a day and a single daily dose for 10 days.
Very good. Excellent. Thank you very much. Are there, Vishali?
After the discussion is over, something for the attendees, just the announcement.
Okay, so are there any final comments from anybody with regards to this topic? I think this was very timely. Yes, yes, Rima?
I said thank you for having me here.
Christina?
I just would like to say that syphilis is a curable disease. So we have to consider it for every uveitis. Put this exam, which is not expensive, very easy, at your files and ask for every patient and treat them right away. So it will make a difference in life for your patient. So I'd like to thank you for the opportunity to learn a lot with you all, and I hope to see you very soon. Bye.
Thank you very much. Any other comments? I think, we learned a lot about the history from Carlos and how, Europeans can be blamed. And interestingly enough, you're not blaming the Brazilians, are you, Carlos? In this disease?
Never blame the Brazilians. And Francesco exempted the Italians from any blame as well. So we feel that it's nothing to do with Italy. And
I noticed you didn't involve the Dutch either into this
no,
disease.
No.
We got a good overview of epidemiology. I think the microbiology, Yolanda did a wonderful presentation. Christina, you explained very clearly how well the response is to treatment with steroids or without, but mainly with the use of steroids. Imaging, I think, Francesco, you did a very good job to show how, the imaging can help. And that was further supported by what Deborah said. And I think, Rina, you explained very clearly what the different tests are, with the possibilities of new ones with PCR that are coming up in the near future by the sounds of it, although at a considerable cost. And we do have to be careful of cross-reactivity, but that obviously is not a major concern, even in areas where there are endemic diseases that, can cross-react. So with that, I'd like to thank everybody. We're just on time, and Vishali has a few comments.
Yes, thank you. And we have quite a few new members joining. So you will all receive an email within 1 to 2 days by Monday about this. Please evaluate, send your comments so that we can improvise it in future. And within 1 week, you will receive your certificate, because this has a CME accreditation. So that you will receive only once you evaluate and send the completed form back.
And if you have ideas as to what we should do next after we finish this webinar series, we still have 9 coming up, but when we finish, we're going to think about a change to a new format. Please give your suggestions or topics or other things that we should look at. It's a commitment from our side, but we certainly like doing it.
And Mark, just one thing, I'm also part of the education committee, so I'm going to be linking up.
I'm very sorry. I'm very sorry.
You left me out. It's okay. I wasn't upset. Okay, it's okay.
I'm in the background of the committees,
But I will be joining the efforts to improve that. Thank you.
Yeah.
Sounds very good. Excellent.
You guys have been with us for 21 months, and we do hope to see you on 3rd of December on a very important topic of VKH. Thank you very much. Thank you, Mark, Carlos.
Thank you. Thank you, everyone, and have a good weekend.
Thank you, everyone.
Thank you.
Bye-bye.